When a chest pain specialist can identify the true cause in only 16% of patients, yet every patient rushes to him, and in more than 50% of cases the cause remains unidentified, while many elderly carry harmless blocks, it raises a chilling question. How many unnecessary procedures are being performed? Hard to believe. Watch the full video on the Tryincurable channel and decide for yourself. The chest pain myth that's killing doctors. This truth could save your heart, your life, your family, your patients. Most chest pains aren't heart attacks yet. Fear still pushes patients and even doctors into unnecessary stents. Know the difference between a real emergency and a condition that can be treated without rushing to the cath lab. My professor had the best medical care. First heart attack, stent. Second, another procedure. Third, and he was gone. Stents, bypass, medicines, all failed. He never changed his diet, the fuel that kept building his blockages. Celebrated cardiologists who still fell to heart attacks. What are we missing? If even the giants of cardiology can fall, something vital is being overlooked. This video reveals the critical truths many in medicine still miss. Call to action. The great blunder of modern medicine. How many more must fall to overdiagnosis and misdiagnosis? Obsessing over 0.01% cholesterol, while ignoring 99.99% visceral fat, trusting glucose and HbA1c tests that reveal only the present and past but hide the future, which only insulin testing can expose, and overlooking the silent killer, fatty liver. Together, these three form the deadly health triangle, almost never taught, never measured, never corrected. Watch it from start to finish. If even one insight is new, it could save a patient, a colleague, or you. Then share it, so together we can narrow the mystery of unknown heart attacks. I'm Dr. Sudhakar Tirupathy, pediatrician and holistic health practitioner. Welcome to Tryincurable, where we question outdated beliefs and reveal the truth with science and ancestral wisdom. If you care about your health, or someone else's, share this video. You might be the reason someone wakes up, and they may thank you with all their heart. Thank you for joining us on this journey to better health. Stay curious, stay healthy, and remember, knowledge is the best medicine. The deadly health triangle, the primary fuel for heart attacks, remains misunderstood and ignored. Misdiagnosis, and worse, overdiagnosis, crushes patients with needless suffering, bleeds them financially, and leaves scars that last a lifetime, while profits take priority over lives. And that's why the danger never ends. 1. Gold standard versus prevention. Every time a doctor dies suddenly from a heart attack, we hear the same lines. No bad habits, ate normal food, exercised regularly. But does anyone ask about his insulin levels, visceral fat or fatty liver, the silent trio responsible for most modern lifestyle diseases, including heart attacks? Our goal, in today's era of advanced technology and skilled cardiologists, no doctor or anyone should die of a heart attack without knowing the cause, whether at 30 or 80. The blocks shouted loud, collaterals buried in silence, never asked, never told. The percent block illusion. A big block doesn't always kill blood flow. Your heart may have natural bypass vessels. They often form gradually in people with chronic or slowly progressive coronary artery disease, even in cases of severe blockages. Rentrop studies show up to 70% of severe blocks have collaterals, yet doctors talk blocks, not backups, and that silence can cost you. Every time a patient is told, you have a 70% block, you have a 90% block. The next words are almost always, you need a stent or bypass. But here's what they don't tell you. Your body often grows its own natural bypasses, collateral circulation. They can keep you symptom-free even with severe blockages. Studies show 20–25% of people with normal angiograms already have these collaterals. In complete blockages, up to 70% have them, yet it's rarely mentioned. Why? Because collaterals don't sell procedures. Percentages do. The real question is not how much is blocked. It's why it got blocked in the first place. And that why almost always starts years earlier, with the deadly health triangle: insulin resistance, high visceral fat, fatty liver, Fix these first, and you attack the root cause. Leave them unchecked, and you'll be back for your second stent, and maybe your third. Remember, stents treat the crisis. Food and lifestyle treat the cause. Don't just clear the roadblock, stop the landslide. Your life depends on it. Doing angioplasty without fixing the root cause is like trimming weeds but leaving the roots. They always grow back. Yet most doctors are trained to keep trimming, while the roots get little attention. The real prevention lies in correcting the deadly health triangle. I urge every doctor to watch my YouTube video, Deadly Health Triangle, the hidden cause of disease. Doctors don't see, link in description box. Even if LDL and HDL are normal, measure a polypoprotein A1 and a polypoprotein B and their ratio, the strongest lipid-related predictor of heart attack risk. Inter-heart study involving 27,000 participants. ApoB high plus ApoA1 low signifies high risk, even with normal cholesterol, by revealing hidden risk from excess small, dense particles, common in insulin resistance. Your cholesterol test is lying by omission. Normal numbers can still hide deadly small LDL particles. Ask for ApoB and particle count before you trust it. It's not about high cholesterol. It's about too many small, dense killers, high ApoB and too few cleanup crews, low ApoA1. These stealth particles, hard to detect with routine cholesterol tests, slip into artery walls, oxidize, inflame, and build unstable plaques, and can rupture with little HDL to clear them. The mess grows until one rupture triggers a clot and a heart attack. When this plaque, a fatty inflamed deposit, bursts open, it triggers a sudden blood clot that can completely block the artery, stopping blood flow to the heart muscle. This is what causes a heart attack. The ApoB/ApoA1 ratio predicts this far better than LDL or total cholesterol, yet most doctors don't check it. Evaluate serum homocysteine levels, noting that each unit increase is linked to a 6% higher risk of death from coronary heart disease. In emergency situations, high-sensitivity C-reactive protein helps. If all are normal, only then proceed further to CT calcium scoring and CT angiography. They are not perfect, but they are non-invasive, widely available, and improve compliance. Cardiac catheterization remains the gold standard for diagnosing coronary artery disease only if necessary. But wait, skip the rush to angiogram. Find the cause hidden in the deadly health triangle. Why it matters: stents treat the crisis. Food treats the cause, root cause testing, before coronary angiography ensures a complete evaluation. Without it, the assessment remains incomplete. Most of the time in heart conferences goes to stents, bypass, new drugs and scans. But real heart attack prevention, fixing high insulin, visceral fat, and fatty liver with proper nutrition, gets almost no space. Instead, the focus stays on just controlling sugar, pressure, cholesterol, and weight. 2. Collateral circulation, nature's backup plan. About 1 in 4 people have natural bypass vessels, collaterals, even when angiograms look normal. Incomplete blockages, approximately 70 to 95% show these vessels, often without symptoms. Collaterals can keep the heart muscle safe, even with severe narrowing, by supplying blood beyond the blockage. Multiple studies prove that the heart can grow natural bypass vessels, called collaterals. The Rentrop study proved a game changer. A 90% block isn't always a death sentence. Collaterals can save your heart. Block percentage shouts, but collaterals decide who lives. Werner's collateral connection grading shows that larger, well-formed collaterals. Pressure and flow tests, like the Collateral Resistance Index, confirm these vessels work, not just look good on scans. In chronic total occlusion, CTO patients, strong collaterals keep the heart muscle alive and improve recovery. In heart attack, STEMI cases, good collaterals mean smaller damage, better circulation, and more stable function. Non-diabetic patients benefit most, with better pumping power and fewer problems. Even arteries outside the heart, such as the internal thoracic arteries, can send blood to the heart in emergencies. The infarcted area in myocardium, subtended by a CTO, is generally limited. Well-developed collaterals are associated with less myocardial scar and enhanced preserved function. However, viability was regularly present in patients with poorly developed collaterals. Together, these studies prove collaterals are real, functional, and life-saving. All links in description. Why are many stable patients still rushed into stenting? An outdated emergency care mindset, blockage means fix now, continues to drive decisions, and limited awareness about the heart's natural protection through collaterals, the deadly health triangle's role in triggering heart attacks, and how diet can powerfully prevent them. Patient fear. 90% block sounds like a ticking time bomb. System incentives often favor procedures over observation. The right approach for stable ischemia. 1. Stabilize first. Control symptoms, tackle risk factors. 2. Optimize medical therapy. Anti-anginals plus lifestyle. Fix the deadly health triangle. Insulin resistance, high visceral fat, fatty liver. 3. Intervention is essential in STEMI, high-risk unstable angina, left main block, severe triple vessel disease with low ejection fraction, refractory angina despite optimal therapy, and in life-threatening states like cardiogenic shock or post-cardiac arrest. What the evidence says. In stable heart attacks, we have time to think. Courage. NEJM 2007, Ischemia, NEJM 2020, and AHA-ACC guidelines show PCI does not reduce death or heart attack risk compared to optimal medical therapy. Its main benefit here is pain relief, not life extension. Stabilize first. In stable angina, watch closely and give lifestyle changes a chance to work before rushing to procedures. All scientific evidence is in the description box. Key takeaway for chest pain? Emergency PCI, life-saving in unstable patients? Minutes matter. Stable PCI, comfort, not survival. Stop scaring patients with percent block as a death sentence. Start reassuring them. Nature's collaterals often protect the myocardium. Avoid unnecessary procedures. Update our thinking. One heart, one life. Care decisions should be patient first, not procedure first. Closing thought. A 90% block is not an automatic ticket to the cath lab if the patient is stable. We can often buy time, treat the cause, and let patients choose from a position of knowledge, not fear. Sometimes, the smartest move is not to rush. Drugs after stenting protect the stent, not your metabolism. Only food, lifestyle, and root cause correction protect your future. Don't wait for the crisis. Understand the root and act before it attacks. Textbook gap. Why modern thinking differs. Harrison's Internal Medicine and Guyton and Hall's Textbook of Medical Physiology focus on blood glucose as the main diabetes marker. Type 2 diabetes is described as 1. Insulin resistance 2. Progressive beta cell dysfunction 3. Chronic hyperglycemia. Insulin is presented mainly as a glucose-lowering treatment, not as a driver of disease. Chronic hyperinsulinemia is acknowledged but framed as secondary to insulin resistance. Modern metabolic research, Kraft, Fung, Ludwig, Taubes, sees high insulin as the starting point, driving visceral fat, fatty liver, and insulin resistance years before glucose rises. Insulin test saves more lives than insulin shots ever will. 3. Misdiagnosis. Fear drives many to rush straight to cardiologist and angiogram, fueled by the false belief that every cardiologist can pinpoint the exact cause of chest pain. Reality check. In a truly national study published in JAMA Internal Medicine 2016, Renee Y. Hsia et al. Analyzed data from the National Hospital Ambulatory Medical Care Survey, a dataset representing emergency department visits across the entire United States. The research examined 10,907 emergency department visits for adults aged above 18 years from January 1, 2005 to December 31, 2011, over 7 years where the main complaint was non-traumatic chest pain. Only 1 in 20 cases, 5.1%, were due to acute coronary syndrome. The most common diagnosis, seen in 51.7% of cases, was non-specific chest pain, meaning the doctor could not determine the cause. The rest had nothing to do with the heart. In 51.7% of chest pain cases, the true cause remained unidentified. With so many patients carrying harmless blocks, How great was the chance of needless stenting? Chest pain, the overlooked cause. Doctors aren't trained to see. The most common cause of chest pain is often constitutional, not cardiac, yet most modern doctors have no training to recognize it. I've treated many patients whose chest pain persisted even after stents or bypass surgery. Case 1. An anesthesiologist lived with chest pain for 9 months and 9 days. First, a stent was placed. 5 months later, bypass surgery was done. Pain continued for 5 weeks afterward. After her stent, she was put on a cocktail of drugs to prevent angina, stroke, and bad cholesterol. For the next 6 months, chest pain never left her. She shuttled between orthopedics and cardiology. The cardiologist's explanation: pain can last 3 to 6 months after a stent, may be a rare genetic problem. Occurs 1 in 100,000 repeat angiogram. Stent blocked. 2 new blockages. Bypass now a must. She underwent open-heart bypass surgery, yet for 5 agonizing weeks afterward, the pain raged on, so severe she couldn't even sleep. The same chest pain that haunted her for 9 months and 9 days, despite stent and bypass, was gone in just 12 hours after receiving a constitutional remedy, something modern medicine is not trained to recognize or use. Within 12 hours of starting her constitutional medicine, the pain was gone. If a stent blocks in just 6 months, what was the purpose? And if the cocktail of drugs can't stop new attacks or stent blockage, then why were they prescribed in the first place? The problem is that prescribing medicines gets far more importance than identifying and treating the root cause of the very same blockage. Why? The real cause was linked to her constitution. Ulcerative pain relieved by pressure. The doctor's own testimony is in this video. How specialists mistake common chest pain for a heart attack, but it is in Telugu. Link in description. Case 2. Another patient had chest pain for 18 months, worsening after bypass surgery. Pain came only in one position, lying on her left side, and while walking in open air. Pain that strikes in the open air but vanishes indoors, not your typical stable angina. And its persistence even after bypass surgery is a red flag screaming for answers. With constitutional treatment, she was pain-free in 1 day. Her cardiologist had treated a symptom but missed the underlying cause entirely. The reason for chest pain often hides outside the lab reports, in the details in position, in movement, even walking in open air, and what eases it can reveal the truth, if you study the patient, not just the disease. Sir William Osler, often called the father of modern medicine, famously said, "The good physician treats the disease. The great physician treats the patient who has the disease." The problem is that a good physician often focuses too narrowly on the diagnosis, test results, and treatment protocols, the very approach modern medicine emphasizes. A great physician goes beyond the disease, understanding the person, their life, environment, and unique circumstances, collectively known as the constitution, and treats the patient as a whole. Lesson: not every chest pain is a blocked artery, and not every cure is in the cath lab. If you find this information useful and trustworthy, please share it with your fellow doctors so they too can know the truth. Don't forget to like and subscribe.